Welcome, everybody, to another episode of Mission by Design podcast. Today, we have two very special guests, but one in particular. One, I have a new co-host today called Ethan Selvin, and the other is the president and CEO of the University of Texas Medical Branch and Health Services, Dr. Reiser. Dr. Reiser, thank you so much for joining us today. How are you?
I'm feeling great, and thank you for the opportunity to discuss healthcare innovation with you. Really appreciate it.
Thank you. Thank you. Ethan, do you want to kick us off and just kind of get right into the thick of it?
I absolutely would. Thanks, Bio. So I'm Ethan Selvin. I work in the academic medical space with Microsoft nationally. I am pleased to be joined by Dr. Reiser today, who we have instantiated a partnership with. Dr. Reiser, thank you for joining us. Could you tell us a little bit about yourself as we get started?
So my name is Jochen Reiser. I'm an MD PhD from Germany, born and raised in the Black Forest area. I studied at the University of Heidelberg and then came to New York 25 years ago to do internal medicine training and a postdoctoral time at Albert Einstein College of Medicine in New York. Then I was at Harvard Medical School at Mass General Brigham to become a nephrologist. Then I started to be the chief of nephrology at University of Miami before being the chair of medicine at Rush University in Chicago for 11 years. And a little bit over 2 years ago, I came to UTMB as the president of UTMB and the CEO of the UTMB health system. And it's been a fun ride ever since. And yeah, it seems like not a boring day.
That's an amazing journey from practice to leadership and probably everything in between over the course of time. And so we first met over the course of the summer when I was honored to come down and speak with you and your cabinet. And in the course of doing that, I always do some research on the folks that I'm going to be talking to. I ran across some amazing research that you did on SUPAR as a biomarker, as an early biomarker for chronic kidney disease. And I'd love to talk a little bit about how that can affect population health and that can affect the societies that places like Rush and University of Texas Medical Branch serve.
Wonderful question. Well, thank you. So I'm a nephrologist by training and a physician scientist. And a long time ago, I was stumbling over this molecule, soluble urokinase plasminogen activator receptor, SUPAR. And it's a molecule that comes from the innate immune system and regulates kidney function and cardiac function in particular. And the higher the plasma levels of SUPAR, the more likely people will develop kidney disease, or the more rapidly kidney disease will progress toward end-stage kidney disease. And so obviously a molecule like that was really a home run. That's why I stuck with it for over 25 years now. I also am the founder of a biotech company, Walden Biosciences, which is now a clinical phase 2 company in Cambridge, Massachusetts, developing an antibody against SUPAR. It is a great molecule for management of populations because everybody has a SUPAR level. We all do. And the level directly speaks to our risk of either getting kidney disease or for rapidly progressing existing kidney disease. And so with that, we can manage much better populations and patients. I give you an example. If somebody is 70 years old and the kidney function naturally has burned down to a certain level, it happens to all of us, the SUPAR level may give you an additional risk estimation how long those kidney might last. And this is very helpful when it comes to initiating treatment or just sort of like wait and see and let's follow up. One example. The other part is transplantation of new kidneys. If the SUPAR level is high before transplantation, there's a higher risk that the new kidney might fail faster after transplant. And so it has really helped us to gauge the risk of kidney disease. And interestingly, and science has shown this, we and others have published a lot of publications on that SUPAR is also a cause of kidney disease. And because of that, we are neutralizing it with a monoclonal antibody.
Oh, fascinating. So getting into the proteomic space.
We're getting into the proteomic space, but we're also getting into therapeutic space. And I talk to my 3 children around management of kidney disease because kidney disease is something that we will only feel later in life. Even if you have kidney disease, it's like driving a car with a full gas tank or half a gas tank. You don't see any difference. It doesn't feel different. But once you reach that last 10%, you get alerted, oh, I'm running out of gas. And so it's really important that we have molecules that help us surveying our kidney functions. And as I said, I'm trying to explain this to my children. Not everything happens right away with disease. There's a progress and a process. And if we can interrogate that process and that progress of a disease, we can manage it way better and also prevent it at times.
So that's interesting, thinking about managing it at the individual level, but I also am thinking about it from a population level, from a bioinformatics perspective. Um, some of this monitoring and some of this insight probably affected the work that you were doing at Rush, given the population health differences across the various different zip codes in the city of Chicago. I was actually up there this summer right after I talked to you, and Dr. Latif had amazing things to say about you, Dr. Latif, who is the CEO of the Rush Presbyterian System. In the process of that, he was talking about managing populations in Chicago. How has your work as a researcher affected your clinical practice and your insights into how to help everyone have a better medical experience as they age and their chronic conditions progress?
Yeah, this is a great question. I think that there is a big cleft today, and still is, between what we know academically, what we know from research, and what we're actually doing today for the patients. We know a lot about kidney disease. We know genetic risk, we know biomarkers, we know levels of inflammation. And remember, SUPAR is not, hopefully not yet, but soon FDA approved. It's not today. So we can't really use it for the management of patients, yet the information exists. And so I see myself through my experience, but also in the role I am, as somebody who's bringing medical advances very safe, but also more rapidly into real patient care and management of populations. And I can tell you, if you just look at SUPA levels, for example, across a larger metropolitan area, you can almost go by zip code and you see differences in the level of inflammation reflected by a different level of SUPAR in the blood of people. And when you then look is which is more urban, where is more stress in the community, where is lower income, socioeconomic issues, it links together with inflammation. But right now we are not using this information in a way it really benefits the patient. So there's a lot we can do. And for that, we need technology. And technology is something that you innovate in at Microsoft. And that's why we're excited to work with people from your company and with companies like Microsoft and others to harness our new ways of approaching those large data sets and making them useful for populations so they live healthier, longer, happier.
Absolutely my passion, and one of the main reasons I'm super excited to be working on the island. I'd love to talk about additional biomarkers and bioinformatics that you're thinking of as you begin to start addressing the population around Galveston. I know that you're looking to gather biomarkers from 10,000 folks here in the immediate future. There's a lot of really interesting possibilities in terms of being able to manage chronic conditions. What are some of the initiatives that you're thinking of in the immediate term?
Yes. So Galveston is a very unique place. It's very diverse. We have literally a snapshot of the entire Texan population in this beautiful 32-mile wide island. Sometimes we call it Houston Beach, but it's really Galveston. And if you disconnect the causeway from it, you have essentially a New Framingham type study. So we are planning to, and we have begun with that, to study 10,000 Galvestonians from a sample from the entire island, understanding the genetic setups, understanding biomarkers, and particularly as those information will relate to a risk for cardiovascular disease. This is an initiative out of our new cardiovascular department that we formed just a few months back. And we also have a Sealy Heart and Vascular Institute that came with it. Dr. Hani Chinet is the director of the institute and the chair of this new department. And our key initiative for the population of Galveston is the Galveston Heart Study. And we think we can derive a sample, obviously in agreement with all the probands who want to be participating in that study. We can derive a sample as an average out of a good chunk of Texas population. And with this information, we will do much more personalized treatment options for cardiovascular disease prevention and for treatment. We're excited about that. And I think this is one example where we can make use of larger data sets in today's care of patients. And this is what I hinted at earlier in our conversation, that we got to bring the technological advances into patient care faster, obviously with the proper oversight, but AI will help us to do that. Now, let me just say that as a nephrologist, it's a daunting exercise to go and see a new patient with chronic kidney disease and screen through all the tests and literature, go to the medical records online or paperwork. It takes a lot of time to find all the pieces that are necessary to understand someone's kidney disease. With AI, we are able to screen this information in a few seconds and derive a very complete picture of this particular patient's kidney disease. And that's what I'm looking forward to, because this will allow us to apply so much more information in a meaningful way and tailor therapeutic approaches in each patient, because every patient is different. They might have the same disease, or we think it's the same disease, but it's really not the same disease. It's a manifestation of the same disease with particular characteristics, and understanding those through AI will help us treat the disease much better.
That's fascinating. And so talking about the complex systems that exist inside of a patient, I'm also thinking about a book I read by your chief AI officer, Dr. Peter McCaffrey, where he describes academic medical centers and the systems that they support as being complex adaptive systems too. Like an individual patient, they have many different inputs, many different signals. And in order to be able to perform the best, we need to be able to process all those signals, just like we're processing the biological signals inside of a patient, to do things like increase throughput, to do things like reduce time in ED, or release people back out to ambulatory as quickly as possible. Thinking about artificial intelligence in that regard as well, both for direct clinical care and for clinical operations, what are some areas that you think are ripe for disruption in the administrative and operational processes that can also increase quality of life on the island?
Yeah, so you describe a process or a problem we have in healthcare that I call the black box problem. Once you are able to enter a health system, which by itself is challenging, right? We're not talking here open table and reserve a restaurant, because
Right.
you need the provider, you need the space, you need the expert, and you need the patient being ready. And then you need tests, and you have to coordinate all of this and make it happen. But once a patient is in the hospital or in the clinic, we don't really know what's going on at any given moment in time. Is the patient now getting labs? Is the patient already back? Is the result ready by the radiologist to be read? And so there's a lot of synthesizing work we can do through AI that makes this faster, easier, and really elevate the patient experience, number one. So I would like to see the apps and devices that give feedback back to the patient where he or she is in the queue of her or his process. That's one thing. But it also coordinates all the specialists together, right? If the X-ray is back and you don't have to always check back in, but you get an alert and you see that the X-ray is back, that provider who manages the care of the patient can continue with providing very important patient care. So we have a lot to elevate through AI, which I call the patient experience. I think that's going to get a lot better. But the provider experience is also getting better through AI. For example, ambient listening, very important, like the DAX Copilot. where the patient is really the centerpiece of the physician-patient interaction. You can look in the eye of the provider and vice versa. That's where humans are strong, to make that human connection and being allowed to focus on that instead of doing clerical tasks and fulfill information on a grid is going to really elevate patient care. Because data shows that if the doctor does not connect to the patient, there's less compliance, there's less healing going on. And I think that with using tools like that, we really can disrupt the workforce. And in fact, at UTMB, I'm pleased to say that we have fully rolled out the DAX Copilot, for example, now to 600 physicians. And we are continuing to roll this out. And patients really like it. The providers like it. They feel less stressed, the providers, at the end of the day. The day is more meaningful. And it directly feeds back into wellness. Because 10 years ago, we thought we should send our providers to the gym at the end of the day. And I'm still thinking that's a good idea. But
Oh, sure, that's great.
right? But it's not what drives their wellness, at least not at the job. It's that coming back to doing what they were trained to do. That having that meaningful physician-patient interaction or that nurse-patient interaction. That's why we went to medical school, nursing school, and we can focus back on that. And it just makes for better outcomes, better patient experience, more successful delivery of healthcare.
So I'm glad that you brought up training, because we're talking about a lot of really amazing and lofty ideas here. And the technology exists, but how we use it, the quip that I use really, really frequently is Microsoft could manufacture the sharpest knife in the world, and it wouldn't be a scalpel until it was in the hands of a surgeon.
True.
Right? And so how can we partner in order to provide the training that is necessary for the medical force of the future, understanding that we're currently in the process of building the digital foundation that's necessary for those tools to be available? How can we partner to empower the physicians, clinicians, the laboratory technicians, administrators of the future to leverage these technologies and do good for society?
I'm so glad you asked that question, because what I have seen, and I take myself here as an example, it took me 2 years to fully engage in large language models and using them myself, right? Because we have a barrier. It's natural. As we learn new technology, it takes a while. So I think your partnership with us, for example, is one good way to make sure that we then, as a university, can put seminars, can put training centers, can put the IT support through Dr. McCaffrey. We mentioned him, and George Getty, our person who oversees all of informatics. Those folks will lead seminars and training sessions with our workforce, because having the tools that you create and we create together is one thing, as you say, but using it, there are barriers. And we need to overcome those barriers by training people, making it easy for them, and allowing them to ask questions. And I think at a university, we are ideally suited to test bed new innovations going forward. And by the way, this was for me as a university president, one of my major key questions that I asked myself in the beginning. How can we make a university in 2025 relevant again? And what I mean by that is, when you are in times where large corporations are doing most of the innovation at a rapid speed, we really as a university lag behind if we don't engage in those partnerships, because we have the students. And the students, and again, I bring up my kids here because all three of them are going either to school, college, and they want to learn at institutions that are staying current and relevant. And so we have a mandate to engage in these new technologies and also make sure that we help to transmit new innovations into practical approaches. And in my mind, this goes only through training, breaking down barriers, interacting with a workforce. You can't do this out of an office And you can't do this just out of a laboratory. You need to really release innovation. And the university is ideally suited to do that. And we have the workforce ready to actually implement those changes with our constituents, i.e., our students, our faculty, and our staff.
I couldn't agree with you more, and it's one of the reasons why I'm as excited about our partnership as I am, and excited to have you on this podcast as I am. I know that we make great technology at Microsoft. Technology is necessary, but not sufficient for progress. And as such, this partnership, while it's wonderful that you're using our tools and that we can work together on a technological level, this partnership is what has me the most excited about working with you and all the folks at the University of Texas Medical Branch. Dr. Reiser, do you have any closing thoughts for us?
Yeah, I'm just very grateful that we have this partnership. I think we have an opportunity at UTMB to define perhaps a new type of a university. We used to talk about learning health system universities 10 years ago. Maybe this is the large language model university, whatever the right term might be. But we can test bed new technology safely with oversight, but with some of the most innovative minds in the world here at UTMB. And from there, we can scale it, hopefully, into the UT system, because as you know, we have many institutions, 14 institutions overall under this umbrella that serve the state of Texas. And I think right now, Texas is a great state. It's ready for disruption. It's ready for this new technology, for the betterment of the people in the state and really in the nation and even in the world. And so, great timing, much more to come. I certainly appreciate the opportunity today to chat about this and looking forward to continue the dialogue and innovate together.
Thank you so much, Dr. Reiser. Bio, back over to you.
Dr. Reiser, thank you. That was such a fascinating conversation. I learned a lot, and it was just really interesting to hear not just the transformation you are providing to patients, but the transformation your organization itself is also embarking on to provide that level of enhanced care to your patients through your productivity gains. So thank you so much for that. I do have one pointing question for you. Just if you were to summarize everything you've said, like what excites you most about the future as it pertains to healthcare, and what can we all do to contribute to that future?
That's a wonderful question. And I'm glad you're asking it. So I think we are living in a cognitive revolution. And so the industrial revolution came before that. Now we're in the cognitive revolution. Maybe this will become a lot clearer in 20, 30 years when we look back. But recognizing that we are in that phase, embracing new technologies, break down our barriers to work with new technologies, and giving it a real try. But also recognizing that not everybody yet is so excited like maybe we are here on this podcast. And so we need to continue to talk about the strength, the opportunities, but also about the fears that come with these new technologies. And we need to bring back the joy of learning, innovation, and of delivering health for our students and our healthcare workers. And AI is really a way to make us more human again. AI for me is actual intelligence and artificial intelligence. And that's the way we have to look at it. We have to embrace the cognitive revolution we are in, and we should be optimistic as we are looking into the future together.
Thank you so much, Doctor. And once again, thank you for being part of our podcast today, and have a wonderful day.
Thank you.